before every station, before the exam. Before you enter in every station, you have to hold up your ID card and you have to read out loud your name and your candidate ID. So this will put a tick here. And you can see there are certain key steps for each case. Usually the key steps are same as the tasks you get, but not necessarily. So again, this is a vague area that we don't have much information about, and the AMC hasn't revealed anything much about this. So in the shortness of breath case, in the sample case in that booklet, we can see that one of them is, let me actually zoom in so you'll get a better view. You can see that one of them is history and checking the vitals initially, especially the oxygen saturation, is another key step. And the diagnosis, being able to diagnose this case. So the shortness of breath case, final diagnosis for this sample is pulmonary embolism, and the candidate should be able to reach the final diagnosis. So that's there. And usually amongst these key steps, if you have gone through feedbacks, you can see that there is something called predominant assessment area. So sometimes it's the history, sometimes it's the differentials. It differs, and when you're performing a case, you'll never know what the predominant assessment area is. But predominant assessment area is the main area that the candidate is assessed throughout his or her performance. Meaning that even if you do a very nice performance, but you do not address the predominant assessment area and you don't perform adequately in that area, you still might fail. So let's have a look at the domains we're assessed in as candidates in the AMC. So there are usually different domains. Again, we have approach to the patient, we have our history. Choice and technique in organization and sequence is usually related to physical exam cases. It's not usually assessed in non-PE cases. And we have diagnosis and differential diagnosis. So in each of these domains, we are assessed from 1 to 7. And finally, we get a global score. So many people might think that the global score is the mean average of each of these domains, but actually it isn't. And again, no one knows, because going through feedbacks, you will come along cases or candidates that have got a 7, a 4, and a 3, but still fail a case. So again, we never know how it's assessed. We just know that for each domain we're assessed between 1 to 7, and we'll get a global score of 1 to 7. A global score of 3 or less means we failed, and a global score of 4 and more, 4 to 7, means that we've passed. So there are little points about each domain that I'll just quickly mention. So we can see here, approach to the patient, it says demonstrated respect and empathy towards the patient, used plain language and active listening. So it means that many people think that they'll get a good approach mark when they empathize. They keep saying, I'm sorry to hear. That is only part of our approach. It does not mean that if we just keep saying we're sorry to hear, we're going to get a good approach. Also, speaking in layman words is part of our approach. Another hidden part of the approach domain is actually when we address patient's concern and problems. It means that if the patient is having pain, we need to address it. If we're in GP setting and we have to refer a patient to the hospital, getting a good approach means to ask the patient, do you have someone to pick you up? These are the little hidden points that increase our mark in the approach domain. Whereas a lot of tutors, a lot of courses just mention that empathy is what increases our mark in the approach to the patient domain. But that's only a part of it. It's by no means limited to empathy. Approach is by no means limited to empathy. Then we have history. If you read through this paragraph, you can see that we will be assessed in the history area. Things that count here is things like starting with an open-ended question, addressing all aspects, relevant aspects of history of presenting illness, and asking the relevant differential diagnosis questions. So these are the factors that increase our mark in the history area. We'll get to the choice and technique if we get to discuss any physical exam cases, so we'll skip it for now. And then finally, we get to the diagnosis and differential domain. Unfortunately, a lot of candidates have a bad habit, and that is they mention the differentials first and then say, but in your case, I think it's pulmonary embolism. But again, it's really important to mention the main diagnosis first, highlight the main diagnosis, and then you can say, I was also concerned of these differentials. And then if your task asks you to justify and say differentials with reason, it's really important that you mention why you think it's pulmonary embolism and why you think it's not myocardial infarction. Just briefly in 1 or 2 sentences. So that's the marking aspect of this exam. If there is no questions, let me know so we can start our psychosocial history, which is our main topic. All right. So I've prepared an algorithm for psychosocial history. At first, this might look a bit confusing for you, for everyone, but in a few minutes, once we go through all different parts of this algorithm, it will be made a lot easier. So we can see psychosocial history consists of one of the main areas of it is confidentiality, which I put in red here. It should not be skipped, and it's really important part of it. A lot of people think that psychosocial history is different from other cases in medicine, surgery, or pediatrics, and they might by mistake skip history of presenting illness, but that is a big mistake they are making, because in any case in medicine, whenever anyone's trying to take history, they should always address history of presenting illness. Then you can see a few mnemonics here, which we will discuss later. Mood and anxiety is here. Psychotic features, organic, and again, going back to the roots of our knowledge of medicine, we see past medical history and family history is also there. So what I'm going to do today is that I'm going to elaborate this algorithm for you guys, and we are going to make a psychiatry a bit more structural so it can make more sense. So again, this is the format. So thing is, every psychosocial history should cover all these areas, but again, I did not put numbers, I just put bullet points here. This means that it doesn't mean that you should necessarily start with history of presenting illness and then move to heads and then move to moods. You should adapt your history taking according to what the patient gives you. So, for example, if you have a patient, a scenario, for instance, someone who is complaining of difficulty sleeping, it would be really inappropriate to ask, okay, so how's your mood been? It's better to ask about his main complaint first. Like, okay, how long have you been having this? Have you done anything to make it better or worse? And how many hours of sleep do you get? And then move on to different areas. Or another example, a patient complaining of seeing cockroaches, for instance. Okay, instead of jumping into conclusion and asking, okay, how's your mood been? It's better to ask, okay, how long have you been seeing these cockroaches for? What do they look like? Do you also hear them? Did they make any noises? And once you complete and explore that area completely, then you can move on to other areas of your psychosocial history. So it's really important to play along with the role player and decide, according to the findings you get, decide what questions you should ask. But at the end of your psychosocial history, you should make sure to cover all these areas. Okay, so one of the most important parts of psychosocial history is the confidentiality statement. So please open your mics if you have any questions or you have any idea with regard to these questions on the slide. So do you think confidentiality statement is not mentioning it as a critical error? What do you guys think? Do you think we might fail if we don't use a confidentiality statement, if we don't mention it?
I think so, yes.
If you don't feel comfortable, yep. Okay,
I think
all
so,
right.
yes. Especially in terms of, I think, psychiatry cases and
Yes.
maybe gynecology and
Okay.
obstetric.
So the thing is, you got a point, yes. In AMC, we cannot say for sure what's a critical error. It really depends on your role player. So the thing is, let's say you start a case that looks like a psychiatry case. You introduce yourself, you start with your open-ended question, and you start asking psychosocial history. For instance, you start by asking, how's your mood been? But you forget to mention the confidentiality statement. It might or might not be a critical error, but the point is, if you don't mention it and you start asking these questions, because they are personal questions, the patient might not open up to you. The patient's gonna waste a lot of time. They might not give you straightforward answers. They might not be cooperative unless you mention the confidentiality statement. So please do not risk, and please mention your confidentiality statement. So when's the best time to address it? There are two ideas about this question. Some people say that we should introduce ourselves and then mention the confidentiality statement, and then can you ask the patient and tell them, can you please tell me more about it? Can you please open up to me? Another opinion is that another group of people actually believe that we should mention confidentiality. We shouldn't just randomly we shouldn't go autopilot and mention it at the beginning. It's better to ask a few questions, and if we feel that the patient's uncomfortable or really is difficult for the patient to open up, or if we feel like our question is a bit too personal, then we have to mention the confidentiality statement. So which one do you guys agree with? Do you think we should mention it at the start, or do you think we should act more natural and maybe just mention it when we're asking personal questions?
We should mention it at the start because we can't take risk.
Yes, good, exactly. I agree. I strongly agree with this because it's big risk. We might forget, and a lot of people under exam stress forget to mention confidentiality. So it's best to just stick with our own autopilot with this. I usually don't agree with going autopilot and robotic, but again, this is like a big risk, and it's better to mention it at the start. I recommend you guys say it at the start. So what's the best way to say it? How would you guys like to say mention confidentiality.
So, can I tell?
Yeah, sure.
Yeah. So, for example, I have a case, so I'll introduce myself. Like, I'm Dr. Jaspreet, one of the GP in this clinic. Today, I'll be taking care of you. How can I address you? Like, patient will be telling me his or her name. So, nice to meet you, John. So, before I start, I would like to assure you that everything we talk here will remain confidential unless until it causes harm to someone. In which case, I might also have to disclose the information.
Okay. Okay. All right. That was good. Okay. So the thing is, actually, there are. If you go to Australian websites like Opera, I think back when I used to study, there was there were a few websites that I came across and mentioned the confidentiality statement. So the confidentiality statement, the actual one, is like a big paragraph. It consists of different parts. For instance, like whatever we discuss today will remain confidential unless there's harm to you or anyone else. And if it is necessary for me to disclose your information, it will be with another professional only for mental health to crack your case, and that was the whole meaning of it. But and the last part of it was that, and I will not disclose the unnecessary details of it, only whatever is necessary. So these are the actual components of it, but again, it's not feasible to discuss like all the aspects of confidentiality. It's best to just stick with one sentence and say it as fast as we can. Just say, okay, whatever we discuss today will remain confidential, or we can just say whatever we discuss today stays between you and me unless there's harm to you or others. That's the one sentence, and we finish confidentiality. Okay. If there's no questions about confidentiality, let me know so we can move on to the next aspect of psychosocial history. Okay, apparently no questions. Okay. Then we go to history of presenting illness. So usually in other cases, like in medicine, surgery, obs-gynae, history of presenting illness, there are a few mnemonics for it, like Sikora, Socrates, and a lot of other different mnemonics for it. We don't need to ask, like it's not applicable here. But there are 4 parts of history of presenting illness that we shouldn't miss in psychosocial history. So there's the onset. How long have you been feeling like this for? How long have you been struggling with this, whatever the main complaint, the chief complaint is? Asking about the trigger. Has anything happened before that might have caused this? This is the way we ask it. Has anything happened before that might have caused this? Have you noticed anything making it better or worse? And the consequences also is really, really important. Like we have to ask, how has this affected your life, your daily life? How has this affected your sleep? How has this affected your interpersonal relationships and your job? And not only in psychosocial history, I want you to bear in mind that even in medicine surgery cases, for instance, in a case of back pain, in a case of neck pain, headache, whatever the case is, heavy menstrual bleeding, it could be anything. If you see that it's quite getting chronic, for instance, it's been 2 weeks, it's been a week, it's been a month, 6 months, you have to ask, okay, you've been getting headaches for 6 months now. How has this affected your life? Are you able to keep up with your daily activities? these are important aspects that a lot of candidates miss in their markdown, and they keep saying, why does AMC mark us down? Because they miss obvious things like this. So if we're clear on history of presenting illness, we can move on to our next area. Okay, next we have heads. Heads is a mnemonic. There are different opinions about what stands for H, what stands for S. Some people say it's not heads, it's head SSS. But this one worked the easiest for me. And if you just stick with this format, you will be able to cover most of the areas of psychiatry. So heads is home.